Good afternoon, everyone. This is Morgan Sims with the McSilver Institute, along with the Community Technical Assistance Center and Managed Care Technical Assistance Center. And we would like to welcome you to today's webinar, The Seeds of Health, Exploring the Impact of Social, Economic, and Educational Determinants. The McSilver Institute, CTAC, and MCTAC have partnered to launch this multi-platform online series intended to help clinical professionals, community health workers, educators, policymakers, and any and all who influence our healthcare system to think critically about those social factors that have a direct and indirect impact on an individual's health and mental health. Throughout this series, we will bring into focus the linkage between poverty, racial disparities, and health inequities, and discuss ways in which these issues can be addressed to improve health outcomes for all. Before we get started, I want to take a moment to orient everyone to the WebEx system so you know how to participate in today's event. Please note that upon joining the webinar, you have been placed on mute to avoid any background noises that may distract others from listening to the presentation today. If you come across any technical issues during today's event, please chat to the host, Brianna, who will be able to assist you. You will have the opportunity to submit questions for the Q&A portion of today's presentation by utilizing the chat box feature, which is located on the right-hand side of your screen. If it is not visible, click the dialog bubble on the top right toolbar, and it should appear. In order to ensure that we are able to answer as many questions as time permits, we are requesting that you send in your questions at any point during the webinar, and we will address them during the Q&A portion of today's webinar. We are very excited to have Anthony Salerno and Peter Campanelli with us today to discuss social, educational, poverty-related economic factors in health disparities and outcomes. This webinar is designed to define and identify the role of social determinants in health, as well as explore strategies to address social determinants and its implications for the healthcare system. Once again, thank you for joining us. I'd now like to pass it along to Tony and Peter to get us started.
Hi, everyone. I'm Peter Campanelli, and going to talk to you a little bit about some of the work that's been done on the social determinants of health to better clarify what they are and how they work, and to crosswalk them somewhat into American culture and American society. But you should know that the social determinants of health are a worldwide concern. They exist in just about every country, and we will talk about some of the global implications of the social determinants of health and well-being. Before we get into that, let me just tell you that, there we go. There is an integrated primary behavioral health program that's out there. It's an advanced certificate program, and we included that flyer in case you might be interested in taking a look at some of the other aspects of health that we're looking at and talking about. And in fact, some of the people at McSilver are doing some research on. So let's start by talking a little bit about the World Health Organization and what they've done with respect to the social determinants of health. They formed a commission about 10 years ago. That commission was designed to take a look at the social determinants of health across a whole range of countries within the world, and so it was a global initiative. Basically, it was created to marshal evidence, to promote health equity, and to foster global movement to achieve it. The committee consisted of a bunch of really good policymakers. And when we talk about social determinants of health, we're going to talk a lot about advocacy and policy. And generally, people respond to this notion of social determinants of health with the question of, okay, so what do we do to help individuals? How does that become an individual intervention issue that we can tackle out in the field? And we're going to try to answer that question as well as we move along. Okay. Slide's not moving.
Peter, you can try using the top arrows, so the arrows that are above the slide deck.
That's where I am.
There we go.
Okay. So defining social determinants of health. There's a whole broad range of issues that determine how healthy we are. the social support networks that we have out there that help us understand what we need to do to maintain our own health and well-being. There are health services, basically hospitals, community-based clinics. There are coping skills on an individual level. There are training programs out there that help us understand how we can maintain our own health, both in terms of in the face of chronic disease and in the face of prevention. There's genetic endowment. There are many people out there who are born with predispositions to things like hypertension, diabetes, and the environment that they're exposed to further exacerbates those predispositions and generally will lead to full-blown chronic illness. There's education. There's a very recent study that the New York City Department of Health has been doing on illnesses across various boroughs. And they've been looking at what the incidence of chronic illnesses in various boroughs. And as you might imagine, it's correlated with educational levels across various boroughs, and it's also correlated with poverty levels across various boroughs. And if you're more interested in the New York City initiative, you can go on to New York City Department of Health and take a look at the work that they've been doing. There's, of course, income, physical environment, and working conditions. And a little later on, we'll talk a little bit about physical environment. We'll talk specifically about the homeless and how the homeless are affected in terms of their own health. There are two principal reasons why health is viewed as a special good. It's viewed as a basic human right. We've heard that term a lot, especially in this election season. But health is generally regarded by both the World Health Organization and the United Nations as a general basic human right. Now, that may sound like it's a no-brainer, but it's not really. Up until very recently, in fact, up until about 2010 when the Affordable Care Act was signed, health was not viewed in this country as a basic human right, but rather as a marketplace commodity. And we've been gradually moving to the universal right of health with the Affordable Care Act, but that wasn't the case. And why is that? Well, health is directly related to a person's well-being. People can only be as productive and as functional as they are healthy. And finally, inequalities in health are recognized as inequalities in a person's capability to function, which severely compromises the individual and makes the individual unable to live productive lives. And we talked a little bit about the United Nations, and the United Nations does, in fact, view healthcare as a basic human right. And you can read on this slide basically what the United Nations says about healthcare and it being a basic human right. And as I said, the United States is starting to move in that direction, although I think we've got a ways to go before we get there. Okay, the social determinants of health. The reason the concept is so difficult to deal with is that it's really a multi-level concept. It's not as simple as treating a disease. It's not even as simple as setting up community access. There is a public health dimension to social determinants, population disease management. There's a public policy dimension to the social determinants of health. Clearly, we basically control on a public policy level things like housing, income, education, employment, and all of that feeds into the general health and well-being of individuals. There's healthcare disparities, and again, access and quality get to be really very important. And we've gotten a lot better at access. There's some studies that suggest that we are actually making inroads since the Affordable Care Act in managing chronic diseases and improving disparities among different populations in terms of access. And then there are individually targeted interventions I think Tony's going to talk a little bit about those as we move along. But those individually targeted interventions are designed to help people understand how they can help themselves. So all of those dimensions feed into the concept of social determinants. These include social, economic, there we go. These include social, economic, physical environment, person's individual characteristics and behaviors. And basically it also includes where the person is living at any given point in time. So there are various theories of social production of health and disease. And these theories are important in the sense that they lead to, or they lead naturally to, the development of interventions when one is trying to address the notion of social determinants of health. They involve social selection and mobility, social causation, and of course life course perspectives. You can't be healthy if you are homeless, living in a shelter, don't have a primary care physician, receive intermittent care from emergency rooms. All of those things get to be really very important when one considers the social determinants. There's a central role of power. This is an interesting slide in the sense that it talks a little bit about people who are disenfranchised and how social power as a collective gets to be very important. We've seen a lot of that recently. In fact, one could argue that the entire campaigning process over the last 6 months in this country has been focused on attempting to establish collective power and to move the considerations of the policy considerations of government in a very different direction. So the central role of power in the understanding of social pathways and mechanisms to the determinants of health basically has to do with the inequities in the political process that engage both the agency and disadvantaged communities and the responsibilities of the state. So this is a state-level issue, it's a national issue, and it's a community-based issue. Second, it's also important to clarify the conceptual and practical distinction between social causes of health and social factors determining distribution of these causes. I'm going to stop here for a second and ask my colleague Tony if there's anything he'd like to add, because I think I'm kind of monopolizing this presentation. Tony?
No, not at all, Peter. But I think it has the issue of control is really critical around all of this. When you don't have economic or social sufficiency, then your power in the world to control events in your life are really diminished. And we do know something about the sense of autonomy, the sense of personal control, something we often call self-efficacy, confidence in being able to achieve your goals, to be able to provide for yourself and your family. When individuals lose that sense of power, that they feel that they're not in the driver's seat of their life, then what you have is really day-to-day stress. And day-to-day stress, we know, in the absence of power, which is really the same as the absence of control, we know that stressful experience has some toxic effects on people's lives. So I think that's a really critically important piece. Power also has to do with the way we've constructed all of the institutions that people either will or will not have access to, or the kind of quality of services that they receive. So I think we'll be able to see that we make the case that having economic sufficiency and power is associated with health and associated with many other things that we would all like to have in our lives. And that's really at the heart of this whole discussion of social determinants. I'll say more about that in a little while as well.
Great. That's very true, Tony. And so what the World Health Organization did and the Commission on Social Determinants, which was actually a very great service to the field, was it began thinking about these social determinants as core issues versus intermediary issues. There are some issues that health flows through and that basically involve individual and sometimes community and state-level interventions. And then there are some that are structural in nature. They're not intermediary, and they're very important core issues that one needs to think about when one thinks about the structure of the social determinants of health. So let's flip to the next slide, and we'll talk a little bit about how the World Health Organization kind of breaks this up. The most important structural issues for the social determinants of health they see as income, education. Income meaning, does a person make enough money to live? Can they afford basic amenities of life? Can they afford health care? Can they afford to buy their prescription? If they do have health care services, can they get that script filled? Is there an economy in the country that basically promotes an upward mobility of people for those who are less fortunate and don't have good incomes? Is educational readily available at an affordable level for people who want to pursue their education? And as I said earlier, education is very much tied to poverty. Poverty is very much tied to illness, and the greater numbers of chronic illnesses that are in communities that experience poverty and whose residents are less educated is not at all by accident. Occupation, are jobs available, and social class, is there a way of being upwardly mobile? Finally, gender gets to be very important, as does race and ethnicity. The trauma of racism can't be escaped, and we'll talk a little bit later about this country's positioning in terms of poverty and in terms of making resources available to families. There's another level of causation with respect to social determinants, and that's the intermediary determinants. Those are the material things. That includes things like housing, neighborhood quality, consumption, potential financial means to buy healthy food, warm clothing, psychosocial circumstances, including stressors, as Tony pointed out a bit earlier, stressful living circumstances and relationships on social support. So if you're living in a neighborhood that is rampant with drugs and crime, it's a known fact that causes stress in your life, which in fact affects your body's ability to adapt and to be responsive to the environment you're living in. That in turn leads to other kinds of dysfunctional behaviors, which in turn leads to unhealthy kinds of interactions. There are, or there were anyway, and that's changing rapidly, but there were many, many fewer access points to really quality health care in neighborhoods that experience that kind of stress. And then finally, there's the behavioral and biological factors, which include nutrition, activity, tobacco consumption, alcohol consumption. We've all seen the ads that New York City has put out on diet, on exercise, on smoking, really good ads that are designed to move a person in a particular direction with respect to behavioral change. It's interesting to note that you could change some of the core determinants, like income and education and occupation, but you might not necessarily get behavior change at an individual level. So both needs to be concentrated upon. This is the conceptual framework that the World Health Organization developed. What's there? I think I lost it. There it is. And it's really a very good framework in the sense that it separates out the core social issues, basically, which are off to the left, and points out the interaction between those core social issues and core social determinants in terms of education, occupation, income. And then it kind of brings you down to a different level of intervention, which is the material things that we all take for granted sometimes, but are not necessarily present in everyone's life at the same levels. And so this is a really good conceptual framework because it, in a sense, helps us understand how we can intervene, what levels we need to intervene at, and helps us further organize those kinds of interventions. Okay, there's one other slide I want to get to. The policy actions are very clear, I think, in terms of this kind of a framework. And we've all been involved in different kinds of advocacy and activities to get policy changes, advocacy activities to get more affordable housing available to people, to get health care available to people, to make sure that people can get into the educational programs they want as early as possible. There's been an increase in early education programs that are out there. All are designed to address some of these disparities and inequities that exist among different populations, and very importantly, basically to enrich the lives of these folks. Take a look at this graph. This is really a very interesting graph. This also came out of the World Health Organization study. They looked at industrialized nations, pretty well-known nations here on this chart: Australia, Ireland, the Netherlands, Italy, Germany. On the horizontal axis, you've got percentage of poverty in the country, and on the on the vertical axis, you've got percentage of poverty in the country. On the horizontal axis, you've got the generosity of that country with respect to providing resources to people who are in poverty and need resources to get through their day-to-day lives. Take a look at the United States and where that falls. We have the highest percentage of people in poverty of the industrialized nations of the world. That was a real eye-opener to me. And furthermore, we are the least generous. Take a look at that horizontal axis. We are the least generous in terms of providing resource support to those people. That's something that if I was just going to guess at, I would have not imagined that that was the case. But this was a study that was done, and it's predicated on data that's out there. And then finally, before I turn the slides over to Tony, there's a couple of other things that I want to go over with you. So what do you do about the social determinants of health? How do you tackle them? What is there that can happen that would be helpful? And so this chart kind of addresses attacking them from a global, a macro, a meta, and a micro level. And basically, if you take a look at what flows out of that chart, there are different interventions at different levels depending on where you're working and what you're doing. So, for example, with respect to individual interactions, there are things that would help people who already have different chronic illnesses and need help in becoming healthier and adopting healthy lifestyles. There are psychoeducational curriculums that are out there that do that, and they're really excellent. They've been put out by places like the American Diabetes Association and the American Heart Association. There's the community. What do you do about the community, and how do you make it a more competent community, a healthier community for people? What kinds of resources do they need to get to that point where they're actually being helped within the community? What are the naturally occurring supports in the community lend to the situation, like, for example, churches and schools and PTAs? Then there's the public process, which isn't always all that easy to intervene in, but it's absolutely necessary. And for years now, we've been arguing for more affordable housing, and it seems like people are beginning to get it. People realize that housing is, in fact, health, and you can't have health without having housing. So there are ways of tackling the social determinants of health, and they occur at various levels. I think if we start thinking about them at those levels, then that's basically a way of beginning to think a little bit about designing interventions that work. Person-centeredness is really very important in this. As I said earlier, There's no guarantee that if you basically improved all of these other contextual resources, that you'd still get a person to change their behavior. So behavioral intervention needs to be focused on it. It needs to be at a person-centered level. And again, that's at the very bottom of the rung, but in terms of levels of interaction, but really very important. So the last two slides that I'm going to talk about anyway are resource insufficiency and the role of science in individual change and behavior change. Resource insufficiency, first of all, is something that we've been tackling in this country anyway and talking about a lot. We've got a long way to go, but we still need to talk about resource insufficiency in terms of things like minimum wage, in terms of things like federal poverty levels and what the federal poverty level is set at, and how we supply people with resources when they can't afford to do that themselves. The role of science in individual behavior change. You know, there's an interesting study that we don't have included in this set of slides, but it's out there that suggests that you can basically intervene in a family's life that's having resource insufficiency by helping them understand cognitively how to deal with that issue, how to help their children dealing with that issue, and to help them deal with the resources that they have available. So there is some study out there that basically, studies out there that basically is beginning to address this. So I'm going to stop here. Tony is going to take you through some of the concerns we have on an individual level, and I'm certainly going to hang around and answer any questions you have at the end. Thank you.
Thanks very much, Peter. Let's see. I'm not sure if I have control over the slides at this point.
You should. Let me see. Am I the one on the side? There we go.
Yep.
Got them now.
I haven't. Thanks very much, Peter. Okay, so let me first let me tell you a little bit about myself and why I've come to really understand that the social determinants may in fact be the critical factor around healthcare. Peter and I are both we're in our 60s. We've been around a long time, and isn't that true, Peter?
Oh yeah, I think you're being kind, Tony.
I'm being kind, and I've worked in as Peter has also in mental health programs and outpatient programs, inpatient programs, working really with the seriously mentally ill. And currently, after my retirement, I worked in addition to McSilver here at NYU with the National Council of Behavioral Health, and there's two major projects that I've been involved with there. One is the SAMHSA project on primary behavioral health care integration. So there are organizations around the country, and maybe some of you who are on the line right now, who are really, the goal was to be able to bring primary care really closer to patients who are experiencing serious mental illness, oftentimes co-located. You guys may have heard about, the notion of integrated care. And because the health outcomes for people with serious mental illness is horrible, and wanting to really address that in some way. And the belief is, and it's a sound assumption, that we need to increase access to primary care services, and that I think is really important. So I've been working on that project almost 6 years with many, many organizations, particularly around the Northeast. But that alone, what's really kind of impressed me is, if we think that just by enabling individuals to have access to primary care services, that in and of itself will really make the big difference in addressing the serious health problems of folks with serious mental illness, whom many, of course, also have to deal with housing problems, economic insufficiency, sometimes their disruption in terms of social networks, that is unlikely to be as critical or to have the kind of impact if all those other factors in day-to-day life are not addressed. The other project I've been involved in is running national learning communities on trauma-informed care. And through that experience, we really have come to learn about the toxic effects of day-to-day stress and understanding really the neurobiology of the human stress response. Human beings are not designed to deal with anxiety and worry and insufficiencies on a day-to-day basis, to worry about one's safety, to worry about basic needs being addressed, and that condition, rather than an event around trauma, is a critically important factor, and it has a profound effect on the human stress system. And I think that those things really need to be understood. And through that experience, I've really come to the fact that those social determinants of health are the critical factors that we need to address. It has implications for the healthcare system, but it really has implications around social policy, our political system, economic system. And we're not going to get very far unless we're able to really begin to address those issues. And I want to make that case. One of the big problems, of course, as this slide presents, is around homelessness. And so many people who really talk about basic insufficiency, right? That is like critical. I've never been homeless, don't know what that's like, and but we can only imagine, right, the impact that has on a person's emotional and physical well-being. And the number of individuals, really, who kind of can get stuck into that almost chronic space of being homeless. And for people with substance use problems and mental health problems, it all comes together. And it's a terrible formula in terms of the outcome for individuals around their basic health needs. So compared with people who do have shelter, right, people with homelessness, here's the problem. They have higher rates of heart and liver and kidney disease, higher rates of diabetes, tuberculosis, cancer, right? Mental illness and substance use disorders run rampant, in this population, right? And so that combination, right, we have the data for it, that if you're having to deal with key insufficiency in your life, it has a profound effect around your health. And in New York City, of course, if we want to go kind of get local, the Coalition for the Homeless, these are some of the reports. So it's big, right? I mean, there's a lot of folks. And then there are folks who may not be in the shelter system, but are, really don't have a permanent, stable, satisfying, safe place to stay. And the disparities, of course, among African-American, Latino population, they're disproportionately affected, right? And it's all linked to the problem of economic insufficiency. And so having these higher rates of serious mental illness, substance use, comorbid physical health problems, it's a mess. And just to look at the economic side, the cost to the system is tremendous. Right? It's tremendous. And so if you were just looking at the sort of the economic impact of economic insufficiency, social insufficiency, of having these comorbid conditions, that ought to be a real big alarm that we need to address. And while there are some efforts to address it, there is a long way to go. Now, in a study done, and it's a very complex kind of statistical kind of like study, these guys who did the study on this, trying to estimate the deaths that really are attributed to social factors. I don't know how you go about doing this. It's a very complex process. But they said, well, can we actually examine that? We know what the incidence of death is when it comes to like diabetes or certain kinds of like illnesses or a cancer, but can we figure out how many people are likely to be alive if it weren't for some of those social conditions? So they made these estimates that if you have low education, 245,000 deaths associated with just the fact that you may not have had the kind of education that would really be associated with managing your health more effectively and successfully. Racial segregation, 176,000. You can kind of see the list here, right? And then in comparison, if you looked at heart attacks, right, we lose 192,000, or cerebrovascular diseases of stroke, 167,000. So the point I think that these guys are really trying to make, and I'm sure folks can begin to say, well, how do you actually determine that? But it's still making the case, and I think there's other evidence for it, that these social factors are not inconsequential at all. In fact, they may be driving much of the health problems that we experience in this country and really globally. So I want to give you just an example of something in the Bay Area in California. They've done a whole analysis of this around life expectancy, right? So people who live in West Oakland can expect to live on average 10 years less than those who are in a more affluent area of Berkeley Hills. And when you take a look at sort of the demographics, you'll see that in West Oakland, in places like Berkeley Hills, the high school grads, 90%, unemployment is very, very low. So in areas where people are in school, where they have employment, when the poverty is low, when there's home ownership, the greater we have in that, you have people living longer. So there's a direct relationship between life expectancy and your economic sufficiency, which is often associated with where you live. So you guys can take a closer look at that. And so you live longer if you have more education. You live longer if you make more money. You live longer if you're white. And so this is just sort of one example of trying to understand, well, what's behind all of that? You know, just all kidding aside, Peter, you may not know this, but I was going to my boss, who you and I both worked for, and I asked for a raise. And she asked me, well, why do you need a raise? For vacation? You want to buy a bigger house? You want a fancier car? I said, no. I want a raise for health reasons. And she kind of like laughed at that, and I was joking about that. But in many ways, and maybe you guys can use this if you're looking to get a raise, is the more money you have, the more economic power you have, you live longer. You're going to be healthier. And so I'm glad I got a PhD. Apparently, getting all those years of education is going to do me better. Right now, of course, for each individual, there's variation. You can't predict for each individual. But in aggregate, my PhD colleagues are going to be better off and live longer and be healthier than folks who have less high school or less than high school education. So compared to a white child born in Oakland Hills, a black child born in West Oakland, right, so an affluent area, an area that's not affluent, these are some of the statistics. This is kind of like outrageous. This should get people like very upset, right? This child is just born there. The prediction would be that their chances, right, these are all probabilities, but just the fact that you're a black kid born in West Oakland, you are already, right, you have a couple of strikes behind you, have more barriers to overcome. Not that you can't overcome them, not that for each individual these are going to be the same statistics, but it does tell us, right, about the impact of the social determinants on a person's entire, on their life, the quality of their life, their health and health outcomes. Peter, were you going to share something?
Yeah, no, you know, you talk about the notion of getting a raise and wanting to get a raise for health reasons. You know, it's also a family issue. So if you look at these statistics in terms of children and the comparison of children born in Oakland Hills versus West Oakland, you also want that raise for the kids that you have responsibility for those children, for the family that you have responsibility for. So this whole issue of social determinants not only affects the individual, it affects the entire family.
Right. Yeah, and it's a very good case and point that you're making, Peter. We're talking about entire communities that are being impacted in this way. So let's just take a look at something simple like physical activity. And you can see these colors correspond to federal poverty level, right? So bottom line, right, the poorer you are, the less physically active you are. Now, why should that be? It could be kind of like surprising, but as it turns out, that's what the findings are. And physical activity, we already know, is associated with better management of weight. It's just better overall cardiovascular functioning. So it's just as simple as that. You begin to see some disparities. If we keep going further, this is basically a global kind of like data, but let's just take a look at this. So if you're in the higher bracket, which is sort of that kind of pink color, highest economic quintile, so you're in the top 20%, versus the people who are in the lower 20%. So what happens? You can see that all of these various medical, procedures, right, from full immunization, medical treatment, attended delivery, medical treatment of various conditions, you can see that you're just better off, right, if you have economic power and economic resources compared to folks who don't. And again, this is associated with poor health and also associated with less lifespan. Life expectancy at age 25. Okay? This has to do with education. This is the point I wanted to make before. People who have higher education are more likely to live longer, right? That's just sort of like a bottom line. Issue. And now the factors that contribute to it, we could probably spend days on discussing what were various variables or factors that are contributing to this data. But clearly, right, the more education you have, and so if you're in poor school environments, if your kids are homeless, who have a whole set of difficulties in terms of keeping up to their schoolwork, if they find themselves, homework, find themselves homeless, if the schools, again, are under par, if there isn't the kind of safe environment in which kids are living, you're kind of starting off, with a couple of really some barriers there to overcome. And I think it's incredibly important to recognize that. And again, here's another case that we're making for the role of social determinants in health. And obesity, you're going to find some of the same things as well, that education helps along all of these sorts of factors. There may be many different reasons for it, but just that alone, if you took all the other factors and you controlled for them, just the fact that you have more education is going to be a protective factor. Cigarette smoking, same thing. The same thing. Folks with higher education smoke less than those with less education. And that has a profound effect around basically lifespan and is associated with so many health problems. Life expectancy of white versus African Americans, right? You can see that this was actually growing. The disparity was less in 1960. It's getting worse, right? So that's another area of this that just emphasizes the role of social determinants in health. So if you have people who have more chronic conditions among adults, 45 years plus, again, how does that relate to poverty, right? So the poorer you are across all these various ages, right, you have 3 or more chronic conditions. It's outrageous. It's tremendous. Both the human costs, the productivity costs, the cost to the healthcare system, the cost to communities. I want to continue making the case. Here's the data for it. Wait, I think I may have skipped one. Let me just see. No, okay, I didn't. Infant mortality. Okay. Again, you can see, looking at some of the global issues. Right? Okay. So we see that there are disparities, both by ethnicity, also of the differences that are affected by the country in which you're living and its particular policies. So how could this thing? How could it be? How could income affect health? Maybe it seems like Tony. That's pretty obvious how it does. But here are some of the issues, right? The nutrition and physical activity options, housing quality, the neighborhood conditions, the notion of toxic stress. When you hear in Chicago, right, that there were parents who literally were going out and sort of dividing their time and location across different streets so that their kids can kind of get to school safely. Just that, imagine what it's like just kind of growing up where you're leaving your residence and there's anxiety about whether you're going to make it to school or not, whether there's going to be gunfights, in the streets. Most of us don't grow up under those conditions. But those conditions create a very high level of toxic stress. And it begins very, very early. And when it begins early in childhood, kids are much more sensitive to the effects of like cortisol, which is one of those stress hormones. And by the way, one of the problems with the stress hormone of cortisol, which really works very, very well when we have to deal with a very immediate and urgent kind of crisis or threat, but in a chronic way, it lowers your immune functioning. And lowering your immune functioning means you're going to open yourself up to disease and illness. So stress due to inadequate resources, problems around medical care and access, and those kinds of things. I'm just looking at the time, so I want to move a little bit quicker. So one issue is the health impact of resolving some racial sort of disparities. So we've had if you had medical advances averted, 176,000 deaths, equalizing the, if we had a greater equalization in the social kind of resources between whites and African Americans, you would probably avert about almost 900,000 deaths. So this quote I think is pretty important, that the prudence of investing billions in the development of new drugs and technologies while investing only a fraction of that amount in the correction of disparities, we have to really take a look at it. It's an imbalance that may claim more lives than it saves. I remember reading an article of a Canadian physician who was working in an impoverished community, I believe, near Toronto. And so he's been working there for many, many, many years and doing what primary care doctors do, which is to prescribe all sorts of like medication for his clients. At some point, he kind of just thought that it was getting futile, that the demands on the life of these individuals, excuse me, day in and day out, that was affecting their health much more powerfully and profoundly than what his medicine could mitigate. So there was a policy, an opportunity in Canada where if you diagnosed your client as having nutritional insufficiency or nutritional deficiencies, then they could get an extra $200 or $250 like a month. So he just decided to, you know what, that's what I'm prescribing for all of my clients. They just need more resources. That's going to improve their health a heck of a lot better than some of the pills that I've been prescribing. And that was one physician's way of saying and sounding the alarm. It's the social determinants that's really driving so much of the illness and disease and health problems that he was observing. So that's like a very important thing, I think, for all of us to sort of recognize. Of course, the government sort of caught on to this and put an end to this kind of over-prescribing of money. I mean, that's what his prescription was, basically. I need to prescribe $250 a month to folks because that last week of the month was a tough week for a lot of people when they just didn't have enough money, or they were purchasing things that were really some of the least healthy foods. I mean, a lot of fats, sugars, carbohydrates that can be filling, cheap, right, but not promoting health. So having safe places to exercise, access to healthy foods, all of these sorts of issues. The social networks. I do want to say something about social networks. And this is something that if any of you have been exposed to the work of the Blue Zone kind of literature, which was really identifying those places on the planet where people live like very old. I'm planning to when I hit 70, I'm planning to go to the Blue Zone where I'm more likely to make it. Peter, you and I should consider moving to a Blue Zone part of the world. Yeah, I think we should. Apparently we'll live to be 100 or so. But one of the things I want to say about these various Blue Zone areas from Okinawa to Sardinia and other places is that one of the factors, in addition to like, the nutrition and people having much more activity in their lives, was the social connections. Social connections, as it turns out, is an incredibly powerful protective factor around health. And it's been demonstrated over and over and over again. And I think an important point is, for all of you who are in organizations, out there, if you're in a position to help strengthen the social bonds and connections of the clients you serve, that's health policy. that's a health intervention. All of the folks who are involved with housing, you may think that you're just involved with finding a person a place to live, but the reality is that you're in the business of promoting health. If you, in your organizations out there, if you have resource specialists or entitlement specialists who their job is to ensure that the client has access to whatever benefits are out there for both economic or housing or other issues, you're in the business of health. So I think part of what's important in looking at these social determinants is that so many of the things that many organizations do doesn't get defined as health, right? It's the doc's job, the nurse. That's where health takes place, right? Or healthcare takes place. And I think one important message to take away around social determinants is that all of those efforts to create, to provide the very basics for individuals so that they don't experience day-to-day anxiety, distress. A colleague out in England who studies poverty a great deal talks about the impact of just day-to-day shame, that there's a lot of shame associated with not having a job or having a poorly paid job, right, or being unemployed and or being homeless. And all of that has a huge impact on individuals. So I think if one message you take away from this whole presentation is that all of those efforts to create a comfortable, safe environment for folks where there isn't insufficiency in those very basic needs, you're in the business of promoting health. Perhaps in many ways you could have a greater impact than the MD who is prescribing a statin or metformin or some other medication. It's just an important thing to consider, and I hope it's one of the takeaways from this presentation as well. So one of the other things is whether or not there's bias, not just around access, but is there bias in the healthcare system? That is kind of controversial and all. But how could well-meaning and highly educated health professionals, basically create a pattern of care that appears to be discriminatory? Are there unconscious biases? Look, the fact is, anyone growing up in our culture, you've gotten many, many messages around all sorts of things related to people with various and diverse ethnicities, sexual orientation, race, and all of those things. Those messages have been basically been here for a long period of time, and in many ways been inundated with this from really very, very young. And so is it possible that well-meaning folks, like myself, a psychologist, right, is it possible that I might have a bias that may in fact either affect the access that the person has to the care I provide, or even in the quality or how I assess this person's need and how I develop a service plan or treatment? Is it possible? So I just want to bring that up because there have been some disparities in healthcare, and you have to well, how do we explain this, right? African Americans are 50% less likely to get heart bypass. Why is that? Less likely to get pain medication. Why is that? Less likely to get colon cancer screening. Well, why is that? Right? So you can see that there's something going on, right? And is it attributed to, is it economic factors? Is there creeping in of some bias in the system? Is there less comfort that clients have or people from different groups in terms of their comfort with the healthcare system? So what is going on? So I do think it's something that we need to explore a little bit more. And so is there bias? As you can see, is there the notion of uncertainty? Is that particular providers treat patients that are dissimilar, let's say, in cultural or linguistic background? Does that affect our perceptions? Do we put on a different lens when we're working with someone who is not at our same educational level or our similar cultural background? Is it possible that it kind of sneaks in there, right? Is there stereotyping, right? Using some cognitive shortcut, making some assumptions about individuals based on their race, ethnicity, socioeconomic level, degree of education, and things like that. I think it's an area that we need to take a look at. And some folks would say that, stereotyping is more likely to occur in situations where there's a lot of time pressure, there's a lot of resource constraint, there's a high cognitive demand, and people kind of take shortcuts, meaning that they don't inquire or explore enough. And if you don't have enough time to continue to explore, you're more likely perhaps to really act out of assumptions that are being made. Again, this is, I think, an area that we need to explore a little bit further, that it can also affect the role. Now, we do know that Hispanics and African Americans are more likely to feel treated with disrespect when they're engaged with, like, healthcare. So you can just see that it goes as high as 18% for people who are Hispanic, 16%, and for whites it's really the lowest in terms of just reporting, answering the question: how does it feel? How do you feel? How well you're treated whenever you have to go to a doctor, right? And maybe it has to do with folks the kind of service providers that they have access to. But in any event, your comfort with and sense of trust with the healthcare system can have a huge impact on the degree to which that healthcare system is working for you. Okay, and here is just some other data on the use of emergency care, by race, and this has a lot to do with the economics of it, around insurance and things like that, which the ACA was attempting to address. So, summary of findings. I think we've kind of made that summary. So, what can we really do about this? So the notion of a person-centered kind of approach, so that we actually explore. It's very unusual to actually have physicians ask about a person's economic sufficiency, right? Although there are examples of folks doing that they want to know if people are having difficulty making ends meet, and appreciation for the fact that if that's the case, then that actually raises your risk around health problems, right? So we have, I know, just 2 more minutes. I just want to go through some of these things. So developing, as Dr. Campanelli mentioned, some kind of an intervention, sort of like, science. Integrate safety and wellness to all aspects of community life, so that we don't parcel out things and separate a lot of silos. Well, that's mental health over there, that's substance use over there, that's healthcare over there, that's housing, over there, there's entitlement service. It's the notion that all of these things will have a huge impact on individuals' overall health. Creating healthy community demonstration, projects, a health impact rating for housing infrastructure projects, to begin to see a social policy that the way we actually design communities, or the way we locate residential buildings and all, there's an aspect around health, and it has a health impact. And really, decision makers in all sectors have the evidence they need to build health into public and private policies and practices. And I think that that's an important thing. The person working in a staff office, provides some, basic services to a family in need, is probably not viewing their work as part of health care. And I mean, it makes some sense, but the reality is that it is. So for helping to assess social factors, I have to say, in all my work, we really didn't do very much of that. And certainly healthcare doesn't inquire into these areas. But that might be, that alone, if healthcare providers actually asked about this, could make a big difference. Insurance companies may be needing to recognize that housing and access to care and all these other resources and social safety net services are in fact health interventions, typically not viewed that way. Collecting and analyzing data regarding health disparities, that's probably one of the most important things, because you can kind of forget or not really understand that there are some glaring health disparities because you're not actually taking a look at it. So we're going to stop at this point, and I just want to really kind of maybe end with what's the purpose of this. This is a basic primer. We just wanted to elevate your awareness and recognition that that education, that housing, that economic sufficiency, that social support, right, and and education and those very, very basics, right, have a huge impact on healthcare. And we will not really improve our healthcare system if we just zero in on the healthcare system itself, that the social factors are critical, And if we develop some policies to recognize that, which really begins to integrate the many, many, many services in a community, all striving to support an individual's health and well-being. So I'm going to end on that, where I know that we ended a minute over, so I apologize for that. Wishing you the very best and inviting you guys to keep very much aware of the webinars and the educational programs that we have here at McSilver. Stay well, everyone, and stay healthy. Bye-bye.
So long, everyone.
Tony. Thank you, Tony, Peter. Unfortunately, we are unable to answer any of the questions. However, if you do have any additional questions, please contact us at ctac.info@nyu.edu. Thanks again, Peter and Tony, and everyone for attending today's webinar. If you have any other questions, like I said, please contact ctac.info@nyu.edu. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. On behalf of McSilver, CTAC, MCTAC, and our presenters, thank you for joining us today, and have a great rest of your day.
Bye-bye, everyone.
Bye-bye.